But I just wanted to point that out to talk about how we are, improving the CPT process. And Chris actually mentioned that this had been worked on for a decade. Well, actually, around 2004, CPT completely revised the E&M codes. And they actually field tested them for about a year before they put them into place, and the revisions were not successful, so it was all repealed. And around 2014, when I was on the panel, they again revised the E&M codes and then sort of held it in abeyance. They didn't officially repeal it, test it. We just wanted to wait and see if it would be something that would require having to go through the RUC process, et cetera, again. And when CMS said they thought it would, we decided to just put it on hold. But we were able to learn from those activities. So it's been a process that's been probably more like 20 years, and I think if I'd been involved, like the first chairman that I served under, Dr. Tracy Gordy, who actually was there when they revised the codes altogether, he would say, no, it's more like a 30-year, 35-year process that we're working on to continually refine things. So I'm going to try and cover mostly medical decision-making, but I'm going to recap a little bit first. So this should actually say current. We made these slides in 2019, so I apologize for that. And as Dr. Jagman has told you, that presently, depending upon the code, you might have 2 out of 3 or 3 out of 3 of the key components of history, examination, and medical decision making. And in some select cases, you can use time as the basis of code level selection. And the time rules today are that for all the codes and also for the Office of Outpatient Services codes are that you can only use it when counseling and coordination of care dominates. In other words, is more than 50% of the service, and it has to be during face-to-face time. So you've already been told what we're moving towards and can see the obvious difference in those concepts. We will be using MDM, and we will be using total time on the date of the encounter. So let's talk about medical decision making. I think that almost every clinician feels that this is the heart of the work that we do. That's what we're trained for, and the history and physical, ordering tests, all that kind of stuff is sort of inherent in understanding the decision-making process, both towards diagnosis and treatment, and that's where you really want to emphasize the complexity. It is also the one thing that was not quantified in documentation guidelines, and they could tell you you're going to get so many points for this physical examination, so many points for this history, but there was no real point system for medical decision making that was universal in the documentation guidelines. Many Medicare contractors had written out materials on how they might recommend this, and there's FAQs. There was a time when I could look on contractor websites and they would actually say these are our documentation standards, in other words, our sort of regional documentation guidelines. The last time I looked when we were going through this process, they had taken them all down as being documentation guidelines and said that they were educational materials. So I don't know if they used them essentially the same way in both instances. I'm not a Medicare contractor. They were helpful, but it meant there was a lot of regional variation.
And also, there was variation within payers in a specific region. So for an individual practice, we were stuck having to meet these guidelines for this payer and these guidelines for that payer, and that was one of the simplifications we were really aiming for in the process.
Yes, thank you very much. Yeah, that is actually one of the major things. It's not just taking away history and examination, but it's trying to create a better national standard that everybody would follow. So that meant that we had to create sufficient detail in the code set to reduce the variation between the different contractors and payers. We also didn't want to just create more words in CPT, although we're all paid by the word, so we do like to do that. We really wanted to make them clinically intuitive, because I think anytime a rule doesn't make sense to you, it's very hard to follow it, even if you're trying to be very honest, right? It's just human nature is that way. We wanted to use the existing tools that were both national from CMS and from contractors, because we did not want to see a change in coding patterns. Now obviously 99201 being eliminated, that's going to be a change in that pattern. We figured most of those would become 99202s, but we were not trying to create any disruptions in coding patterns. We did want it to be fair. There's probably some instances where today the documentation guidelines essentially meant people either had it easy to upcode based upon history and examination for lower medical decision making, or potentially downcode, where they were downcoding because they did a lot of complicated medical decision making, but it just didn't require that much history or examination. One of the things that we did in all our discussions, Dr. Jagman really outlined a lot of the conversations that we had, some publicly and then oftentimes the work group publicly, but amongst ourselves. We always came back to real life examples. So we would, someone would say like, well, I just saw a patient this week and this is what we did. And you're telling me that's going to be this level of medical decision making or this level of whatever. And so we really did try and make it basically real world for people. The other thing that we noted was that the CMS table of risk is something that is national for medical decision making. So it's one component of medical decision making, that element of risk in CPT today. I also, like I think many of us, have taught a lot of sessions on correct coding for evaluation and management. I've done it for my specialty society for 20 plus years. And the one thing that was always easy to teach people was the medical decision-making table of risk, because when you say it's one stable condition or two or more chronic conditions, people go like, okay, yeah, I did that 20 times yesterday, or that type of thing. That's something that somebody can really understand. We also, as I said, wanted to use the contractor audit tools, and we did. We looked at them. The problem is that they were all significantly different. In some cases, the differences were maybe not too major, but in some cases, they were pretty dramatic, at least for some elements. So we wanted to sort of take the best from them and get rid of confusion there. We also looked where we could maybe use better definitions or more detailed definitions of terms such as mild or acute or chronic illness with systemic symptoms that might be in the table of risk. So we did, if we saw a term that we thought would benefit from definition, we actually created definitions. Now, I'll show you some examples of those. You're not going to see everything that's in the new office and outpatient guidelines, but I'll show you a couple of examples. So first of all, I just want to show you the existing, this is the current 95-97 table of risk from the CMS documentation guidelines. So just take a look at the low-level low-level risk, I should say, and they break risk into three subcategories: presenting problems, diagnostic procedures ordered, management options selected. You'll see how we address that when I show you more of the medical decision-making table. And here's the one that I thought was the very easy thing to teach. Two or more self-limited or minor problems, one stable chronic illness, and they even give examples, such as hypertension, non-insulin-dependent diabetes, cataract, or benign prostatic hypertrophy, or an uncomplicated illness or injury, such as cystitis, allergic rhinitis, or a simple sprain. So we did feel that we could provide some additional definitions. Now, some of these are very similar to what exists in CPT today if you look under the section in the guidelines called the nature of the presenting problem. And so we actually are recommending, even in the current guidelines, one of those be changed a little bit so it matches up with the office and outpatient code definition so that there's no conflict. Self-limited or minor problem is a problem that runs a definite and prescribed course, is transient in nature, and is not likely to permanently alter health status. That's essentially in the nature of the presenting problem today, with a very slight modification. For stable chronic illness, it's a little more wordy. I will tell you that part of the reasons why the definitions have a little bit more text to them is because we had these discussions. We had these questions like, what about this? I don't get it. Would you call that stable? This isn't stable. So we tried to make it clear that an illness is chronic, even if it might change. You might go from stage 3 to stage 4 kidney disease, or well-controlled diabetes to poorly controlled diabetes. Well, that's still diabetes. It's one condition. I think that seems pretty intuitive to everybody here and to most clinicians. I think the thing that may be a little more challenging is, how do you define stability? Well, normally, sort of common language usage, stability means it stays the same. well, we didn't want to consider that stable. We wanted it to be more like a good thing clinically. So if your blood sugar is always 500 every time you test it, that is a stable blood sugar. It's not exactly at the treatment goal. So we wanted to make it clear, no, it's at the treatment goal for the patient. So I'm in geriatrics. I have a lot of palliative care type of patients. There's plenty of patients I have where their blood pressure is 170 over 95, or maybe their blood sugar runs 200. Well, if I think they've got a few months left to live and I'm really focusing on comfort, I'm not having them test their finger sticks 4 times a day, giving themselves 4 insulin injections, et cetera. So their treatment goal is that, not the blood sugar of 500, hopefully, but maybe the blood sugar of 200. That's okay. So everything has to be sort of patient-specific. And then we talked about those definitions that were very nice and very educational, like controlled hypertension, non-insulin dependent diabetes, BPH, cataracts. So we said, we don't want those in the table because it just gets too confusing, and I'll show you what the table is going to look like in general. And so we said, well, let's put them in the text here because they are good references for people to be able to have, to use. Here's another example of an acute uncomplicated illness or injury. And I know you have these in the handout materials. So it's a short-term problem with low risk of morbidity for which treatment is considered. There is little or no risk of mortality with treatment, and a full recovery without functional impairment is expected. And then we give some examples. We actually do define other terms. For instance, morbidity is actually a definition that we include just to make sure everybody's on the same wavelength with that type of thing. And as I said, I'm not going to show you every definition that's in the guidelines. There are more. We thought that a table was a good educational reference. I think many times when CPT writes wordy guidelines and the code descriptors and there's cross-references, et cetera, we oftentimes find that people say, you know what would really help is a table that has the CPT code and then a few key points about it. So I can remember working a long time on all the pacemaker revisions and ICD revisions, and it was one of those things that every time you started to look at them, you had to spend about 2 hours getting them in your head straight, and then you could begin to work on them. Well, someone much smarter than me said, well, you know, if we just had a table of all those things, it would be very easy to keep them in your head because they'd be on one page right in front of you. So you see a lot of tables like that in CPT today. And I think definitely medical decision-making is one that lends itself to that. And then the challenge is to make the table simple enough to be useful and understandable. So we felt that a table would be useful, and of course the table is only for the revised codes at this time, and we felt that it was appropriate to include the current levels just as they are today, and Dr. Jagman showed you the code structure, so you know that already. There is straightforward, low, moderate, or high medical decision making, and that has to be reflected in the table. Now, we did take a look at the medical decision making sort of subcomponents or key elements today, and they are number of diagnoses or management options, amount and or complexity of data to be reviewed, risk of complications and or morbidity or mortality. So that last one is where you saw the CMS table of risk. Well, the first one I think is really where we had a lot of discussion and where you could see differences between contractor guidelines. So we actually had some people say it should be really simple. 4 diagnoses, 1 is straightforward, 2 is low, you know, just count up like that. So when you get to 4, it's up to high. And then other contractor guidelines and some of the people that brought this up said, well, it's not the number of diagnoses because there might have been other management options that should be counted. So it's 1 diagnosis, but 4 management options. And so you could see quickly how there could be complication in interpreting that. And although we have contractor guidelines that give you a scoring sheet that you can just add up the numbers, it didn't really seem that consistent. And I think it's one of those things that many of us that have looked people in the eye and said, really? You know, saying, you know, you might say those are 4 management options or in the differential diagnosis, but the last time I heard that a runny nose was a CSF leak, you know, from a head trauma was from a medical student, and not even a 3rd-year medical student. It was a 2nd-year medical student who was doing history and examination and trying to do a write-up. So I think we wanted them to be very practical. The way we changed it is subtle, but I think significant. in January of next year, if all comes to pass, will be number and complexity of problems addressed at the encounter. And it's important that they be addressed, not just that they're on a problem list, because in electronic records today, people have extensive problem lists that may or may not be addressed at all during the encounter. It is the amount and or complexity of data to be reviewed. That's exactly the same, but we said and analyzed. In other words, we wanted to make it not just you looked at something, but you thought about it and mentioned its importance or relevance to the encounter of that day. And it's the risk of complications and or morbidity or mortality of patient management. Now, patient management and patient condition are obviously related. If someone has a very self-limited problem, it's pretty hard to have risky management of it because there may not be any management, and maybe all you can do is harm the patient on a self-limited problem. And if someone has a life-threatening condition, the management obviously is going to be relatively high risk too, because it's either going to save their life or not. But I think in general, they are distinct concepts.
So one of the things we were trying to get rid of was the note bloat and the cut and paste. So when we say that it's addressed at the encounter, that means there has to be some documentation in the note that said, here's why and here's what, and that there's appropriate history and physical that goes along with that. And most specifically about the data that's reviewed, I can't tell you how many pages of documentation there is where there's the cut and paste of the chest x-ray and the cut and paste of the ultrasound, but there's no discussion about what those findings were. And what we wanted to do was eliminate that as much as possible and say what you need to document is that you reviewed it and here's your analysis of that particular piece of data, whether that's a lab report or something else, so that it becomes a cohesive, clinically centered on the patient, relevant encounter that can be documented in as few words as possible.
Right. I always like working with Dr. Levy because she always makes whatever I say better. So we're going to build the table together, okay? You get to be part of this. So here's the basic outline of the structure. You see across the top, first of all, we just list the codes that we're talking about. Then we list the level of medical decision-making. And then we have the 3 columns that we just talked about, the components. So now we're going to sort of fill it in. I only show you the first couple of levels. And you can see for 99211, there really is no level of medical decision-making. The person didn't need to see a clinician directly. They saw staff that helped in the office. So the number and complexity of problems addressed at the encounters, as I said, has been based on the documentation guidelines table of risk. We added numerous definitions, you saw a couple of them, and we moved the examples into the definitions section. So it's going to look a lot like the table of risk, and that's why I comment on those differences. So here we see for 99211, it's not applicable. There obviously was something done at a 99211, it's just not, you don't have medical decision-making level having to be defined for that particular service. For the straightforward medical decision-making, it is minimal. 1 self-limited or minor problem. For the low level, it is 2 or more self-limited or minor problems, or 1 stable chronic illness, or 1 acute uncomplicated illness or injury. This is not our invention. These are the problems taken out of the table of risk. For moderate is 1 or more chronic conditions, illness, with exacerbation, progression, or side effects of treatment. 2 or more stable chronic illnesses. 1 undiagnosed new problem with uncertain prognosis. 1 acute illness with systemic symptoms, or 1 acute complicated injury. And again, that's the table of risk. And then for high, it's 1 or more chronic illness with severe exacerbation, progression, or side effects of treatment, or 1 acute or chronic illness or injury that poses a threat to life or bodily function. Now, we didn't necessarily include everything that was in the table of risk if we thought something was confusing, but we fundamentally adopted that. So I think this is the type of thing that there's a little bit of counting in there, but I think it's fairly intuitive again for clinicians. Straightforward medical decision-making is a self-limited problem. I would say that in most cases, the patient came to you, didn't really need to come to you. I mean, sometimes it's in retrospect, and I'm not criticizing patients, but I think we see a lot of people, especially I'm a primary care person, for problems that if you just read a first aid book or something like that, you didn't need to see me. Low is a stable, uncomplicated single problem, typically. Moderate is multiple problems, or someone's pretty sick. You're not thinking that they're going to die this week or go to the hospital today, but they've got a significant illness, and high is they're pretty ill. You need to do something about it. Now, something about it may be start palliative care. Something about it may be send them to the ICU, call 911 from your office, but you know that they're a fairly sick person. Now, in medical decision-making around amount and complexity of data to be reviewed, we tried to, again, simplify and standardize the contractor scoring guidelines. We tried to emphasize what we thought were clinically important activities that really did affect the medical decision-making and improved patient care. Because remember, in that very first slide, when we talked about our general principles, it was simplification to improve patient care. We feel if people spend more time thinking about what's important rather than doing unnecessary documentation, that would improve patient care. And we also wanted to build that into our medical decision guidelines. However, admittedly, in this particular area, when it talks about number of items that you're reviewing, it's very hard not to have a little bit of counting. So we tried to simplify it, but there is a little bit of counting that I'm going to have to show you. We divided things into 3 general categories. The first is pieces of paper, such as discharge summaries, test results, and those test results could be like a neuropsychiatric evaluation, neuropsychometric testing. It could be an echocardiogram, so it could be physiologic. It could be remote monitoring. It could be anything that you are looking at and reviewing, and as Dr. Levy said, is not just cut and paste, but it's relevant to your consideration of the care of the patient. And we just count each item once. They're not your own notes. You can't refer back to what I did last month or 2 months ago. That doesn't count. We also talked about independent interpretation of tests not separately reported. So if I do an EKG in my office and interpret it and report that, bill that service, I don't get to count that as a document I reviewed because I've already gotten paid for doing it, right? On the other hand, an example of something that happens with some regularity in my practice would be I happen to be lucky enough that just about 50 feet away from my office front door is the X-ray department in our building. It's actually a satellite of the hospital. It's X-ray department. So I see somebody in the office, and I think they might have pneumonia, and I'm trying to decide whether I want to put them on antibiotics or not, and I'm just not 100% sure. I send them down for a chest X-ray. I say, as soon as you're done from the chest X-ray, come back and tell my secretary to come get me. And then I just run out of my office, down the hallway, look at the X-ray, and determine whether I think it's pneumonia or not, and then make my treatment decision on that. Now, I'm not billing for an X-ray interpretation. Thankfully, someone who's much better at reading X-rays than I is going to go ahead and officially interpret that study. But that is what we're talking about, an independent interpretation of a test. So that would increase the medical decision-making complexity of my particular visit. And the third category is discussion or management of test interpretation with an external physician or other qualified healthcare professional. That doesn't mean a nurse practitioner that you're paired with in your office. It means an external qualified healthcare professional or physician or appropriate source. And we don't talk a lot about appropriate source here, but we do define that. It's actually in the consult codes now, but if you're a pediatrician, sometimes you have to talk with school personnel to go over how somebody is doing. Sometimes there's actually criminal proceedings or other things that people are involved in where you have to get involved in rather lengthy discussions. So those count. And this, again, real world example. So that patient, if they didn't have pneumonia, another common example for me might be they have a cardiologist who manages their heart failure, and I'm seeing them in general and also managing their heart failure. So I think my patient's in heart failure. Not severe. I'm not worried about sending them to the hospital. I think I can probably handle it, but I want to go get a chest X-ray, so I do the chest X-ray. I interpret the chest X-ray as showing, yeah, the pleural effusion wasn't there before. It's there now, and I think I see some interstitial edema potentially as well. And I want to make sure the cardiologist knows about this and concurs with my management, so I call the cardiologist up who thankfully I can actually speak to, although I know it's awfully hard for doctors to even speak to doctors these days, but I get through to the office and we discuss the management together. So that is the type of patient that we're talking about. And I think that's the type of care coordination and improved quality care that we're all looking for and want to emphasize. Now, this is perhaps one of the areas where we had the greatest difficulty in pictorially or in a nice, succinct table representing it. And I actually think here we're talking the limited, you can get to limited in 2 ways, and they're actually all in that same category of tests, reports, documents, or independent historian. So maybe we really should have said category 1A and category 1B, and saying you're offering two sub-elements of this category. And we might actually make a change there. But basically, what we're saying is that in this box, if you just look at this box in isolation, you have to do just one of the two things that are there. So one is that you reviewed any combination of two documents, which could have been a discharge summary, another clinician's note, a lab test, echocardiogram, EKG, et cetera, that were relevant, as Dr. Levy mentioned. They were relevant. You consider them in your evaluation. You analyze them, in effect, for their importance for medical decision-making, not independently interpreting them. Or that there's an independent historian. So that is the way that, for instance, the American Academy of Pediatrics is taught the medical decision-making, something in geriatrics that I do all the time. But I also see plenty of patients where, I will, the male patient comes in with their spouse, because I will confess, as a male, we all know that you can't trust anything we say if our spouse is the only one that's going to give the honest answers as to what's going on. So that's not an independent historian. The person is completely capable and competent, even though they're a male, to give you an adequate history, and that is not an independent historian. But for an infant, or I have patients with advanced dementia, absolutely I need to get an independent historian. And in some cases, that independent historian is somebody I have to actually talk to on the date of the encounter to get the information. So that's low-level decision-making of the component of data to be reviewed and analyzed. For moderate, we again have this counting one. Here we said the independent historian just counts as an element. So independent historian is equal to a lab test. I know that's not really the way it is exactly in the work, but we had to come up with something that's simple enough to have rules on, and that's what we chose. So now it's 3, or you have that independent interpretation of tests. So when I ran down and looked at the x-ray, that alone would have counted, or you talk to another clinician. So any one of those 3 categories gets you there. And then for high-level decision-making, you have to do 2 of those items. So again, keep that in mind. This is only in this column. I'm going to show you at the end, but remember, we're going to get to where it's 2 out of 3 of these columns, just like it is today. So it could be that someone is pretty complicated and you're not really looking at much way of the tests at all. They come in and say, I've been having this discomfort. When I walked 2 blocks, I got a little bit of chest squeezing a little squeezing in my throat. I get a little out of breath, and then over the week, it seemed to occur less and less, and then last night I was up for 2 hours. Well, I'm probably going to do an EKG, or in some cases, if they're still having the chest pain right there, I might not even waste time doing an EKG, because I might be running out to my front desk and saying, please call 911, and I'm crossing my fingers that they don't drop in front of me, because I know that's a very serious, high, complex illness, but we're going to have to get them to the hospital pretty quickly. So let's go into a quick summary of that. So the amount and complexity of data to be reviewed and analyzed, for straightforward, it's really minimal or none. There's no, for that self-limited illness, why would I necessarily be reviewing any data at all? Low, you really only need 1 category. Basically look at it as 2 documents or an independent historian. So I think this counting can be pretty easy. Moderate, 1 of any of these 3 categories, and you just go up to 3 documents, or interpret something, or confer with somebody. High is you just have to hit 2 of those categories, so it's either 3 documents, confer, or interpret, but 2 out of the 3 of those. So let's move on to the risk of complications and/or morbidity or mortality of patient management. So the risk of complications and/or morbidity or mortality management made at the visit associated with the patient's problems and treatment. So it's not just a general thing that someone who might have good medical knowledge might infer, but is actually how you treat the patient on that day. So the complications of management, one of the things that we wanted to include was the possible management options selected and those considered but not selected. So that's what always bothered me as a geriatrician about the table of risk and was in CPT, and the changes that I most wanted to see in that 2014 attempt. We got into a lot of other things, but there was 2 things I wanted. Not that what I want matters, but in any event. And the main thing is that there's lots of times where the biggest complicated decision in geriatrics is, I think we ought to not do this. if you were 45 and healthy, I wouldn't be thinking about this twice. We'd just do that test. We would do that procedure. Absolutely. Your particular situation, it's risky not to do it, but I think it's more risky or not consistent with your life care goals to do it. So it's important that that gets credit. And it actually was in the table of risk, if you look to the very bottom, there was a decision to de-escalate care was one of the elements in the table of risk. But we wanted to really highlight that as well. We also thought it's time, as everybody is trying so much now, to address social determinants of health. So in some ways, your question about dealing with insurance, et cetera, is that element. I mean, we do have times where everybody goes like, I know what I would do with this patient. I would put them on this drug. That's nice. They have no money and they have no insurance coverage. And that makes it very difficult to make the medical decision making. So here, again, we looked to the table of risk, and here you see an example of moderate risk in that table related to the management options selected. So this is the closest to that third column that we have, that management options selected. It's the risk of treatment or diagnostic procedures. So again, we pretty much just quoted in our tables, minor surgery with identified risk factors, elective major surgery, prescription drug management, therapeutic nuclear medicine wasn't so much relevant for, we didn't think was a major one to put in these codes. So we left some things off, IV fluids with additives, again, not often done in the office, occasionally. So we just included some of them, and some of these went into the examples table rather than on the table of medical decision making. So here we go for the straightforward, we just put down minimal risk of morbidity and low risk of morbidity or mortality from additional diagnostic testing or treatment, and we blow it out a little bit and amplify moderate. Those are those examples that I just showed you: prescription drug management, decision regarding minor surgery with identified patient or procedure risk factors. This was something that the American College of Surgeons told us is the language that they now use in their educational materials. We said, again, if you've been doing this for a long time, that's not going to change coding patterns. Let's keep with that, et cetera. And then we added the social determinants of health to make it moderate, potentially. And then high risk, drug therapy requiring intensive monitoring for toxicity, and we define that. Decision regarding elective major surgery, decision regarding emergency major surgery, decision regarding hospitalization, or decision not to resuscitate or to de-escalate care. That's actually right out of the current table of risks today. So I think, again, this is relatively intuitive. I mean, straightforward is basically you're not going to be able to harm the patient unless you do something really stupid because the disease isn't going to do anything to them. Low is it's stuff you're not going to make a big deal about talking to the patient for. You might give them something. You have high blood pressure. I'm going to put you on a medication that's called an ACE inhibitor. Sometimes those give you a little cough. It's no big deal. If it bothers you, let me know. Or moderate, this person has got congestive heart failure. They are exacerbating a little bit, but it's just a little bit more edema, a little more weight. I hear a couple of rows that weren't there the last time I examined them. We're just going to up their diuretics a little bit and get a basic metabolic panel in 4 days to make sure we haven't dropped your potassium. That's pretty straightforward. Or maybe these complex social factors type of patient might be the one. High risk is, this is serious. Let's talk about some bad things that could happen with treatment, without treatment. Let's talk about where that treatment ought to occur. So this is the table, and I'm just going to go. This is too complicated, that's why you have the handouts, but this is when it's all put together. So we just tried to build every column separately. And this is actually how we did the discussions. I mean, we took, we'd have one meeting, okay, we're going to talk about data. We have one meeting, we're going to talk about number of diagnoses. Once we sort of built it out, we then knew our way to attack the problem. And this is, you're essentially seeing how we did it. It's all stuff you've seen before, so I'm just going through quickly. And again, here's the point. We aren't changing the current rules that it's 2 out of 3. So as I gave you some examples, it may be that this person has one acute, uncomplicated illness or injury. Okay, they have a significant ankle strain. I don't think I need to order an x-ray on it. There's maybe some risk that I'll miss a diagnosis of a fracture, but I really don't think they have a fracture, and I don't think it's necessary. So there's no data to be reviewed or no testing ordered. And there is a low risk of complication if I was wrong in that decision, et cetera. But again, I think that all fits together nicely.